Good afternoon, and welcome to today's webinar titled Sex and Intimacy After Traumatic Brain Injury, presented by Dr. Tina Trudell. My name is Laura Jacobs, and I am the Education and Outreach Coordinator for the Brain Injury Alliance of New Jersey. We are a nonprofit organization with a mission to provide education, awareness, and support for those who have been affected by brain injury. Today's webinar, Sex and Intimacy After Traumatic Brain Injury, will discuss aspects of sexuality after TBI as changes in sexual functioning and satisfaction are common. It will also explore how sexual expression occurs in the context of intimate relationships, where aspects of intimacy may be affected by depression, cognitive changes, memory loss, and other factors that may occur post-TBI. Also providing new ideas and promoting interest regarding better integration of sexuality into the post-TBI rehab and life experience. Dr. Tina Trudell is the CEO clinical neuropsychologist with Northeast Evaluation Specialists, Northern New England's largest provider of outpatient neuropsychological and functional capacity evaluations. She previously was COO of a national continuum of brain injury centers for civilians and service members, including as site director of the DVBIC program in Charlottesville, while assistant professor of clinical psychiatry at UVA Medical School. She previously supervised postdoctoral neuropsychology fellows at Dartmouth Medical School and contributed over 50 publications to the field, including co-editing the Essential Brain Injury Guide core text for ACBIS certification. She received BIAA's 2008 Founders Award for her work and advocacy in brain injury rehabilitation. So with no further ado, I'd like to introduce Dr. Tina Trudell.
Well, thank you very much for the intro. I know this is a topic that can be sensitive for people, and while we do have the Q&A feature, which will be doing the questions at the end of the talk today, I also have provided on the front cover slide the opportunity to contact me by email if people would prefer not to have questions addressed in that forum. So I understand that that's an issue that sometimes comes up with this topic. I also want to thank my colleague Angel Sander. Almost a decade ago, Angel and I did some workshops related to this topic. She's currently on faculty down at University of Texas Medical Branch in Galveston, and some of the quotes were from individuals from her clinic that we'll be citing in the talk today. Let me move forward in the slides here. So when we're talking about human sexuality, this is a highly integrated, complex activity. And it's one of the most sophisticated things that we do, and it's very much tied up with psychosocial, religious, cultural elements, our own learning, relationship history, what we saw in our own families with our parents. And it's a challenging thing because, obviously, given what an important part of life this is, how do we bring that into rehabilitation? How do we even frame and consider sexuality? So that's some of the things that I really want to be able to talk with you all about today. And the underpinning for me is that pleasure is an affirmation of life, and rehabilitation should be a life-affirming venture. We can't just expect people to be motivated to be in rehab so that they can work 40 hours a week and pay their taxes again. And I know that's often the benchmark, or that they can live independently and clean their own apartment or whatever it is that people are thinking that, oh, this is a good outcome. To be able to be in love, to be able to share intimacy, I'll tell you, for me anyway, that's a heck of a lot more motivating than going to work or cleaning my house. So anyway, that's some of the bedrock of this for me. So where are the roots of this? Well, we go way back to ancient Greece, where there was this juxtaposition between people's body and their soul. And the whole idea of our bodies and the things that occurred with our bodies, including sexuality, were considered equivalent to our animal nature and much of a lesser thing, and viewed to be something, that was almost beneath us. And this idea was incorporated into the early teachings in the Catholic Church and translated through Protestantism as well as coming over to our country through the Puritans. So we kind of have that history with us. And, as someone, my spouse is a dual European Union and U.S. citizen, and I was often shocked early on going to Europe when on TV during general viewing hours, like after dinner, there would be things that were flagrantly sexual or nudity, but there wasn't violence. And meanwhile, the European relatives would come over to the U.S. and watch our TV and see all this violence that they were horrified by, but that we didn't allow anything that was sexual in nature or had nudity. So, we have to remember that our position on this is unique to our history as Americans, as whatever faith we grew up in, as whatever our local community, because there's dramatic differences across parts of the country. So, that's part of the context as well. And then as professionals, we have a history, especially in psych, where we came out of the field of psychoanalysis, where we had this idea of normal versus deviant sexuality that was very much steeped in Freudian Victorian-era thinking. There was evolution of that with Kinsey and Masters and Johnson, who then developed treatments and applications and a knowledge base about human sexuality, that it was okay to study and consider treating this as we would any other human behavior. The problem with that, while these things began to modernize and be applied to the population as a whole, like many other things in life, it was very slow to translate to populations with a disability, never mind the specific disabilities that occur related to TBI. There's also issues that we have to be wary of. We have to make sure that we're not preoccupied with sex versus friendship and other forms of intimacy that people can lose in life after having brain injury or other trauma. We also know that we're really obsessed in our culture with everybody being young and beautiful, and we do all kinds of crazy things to try to hang on to that. And that can be tough when someone has a disabling condition or condition that results in some kind of major change where they don't meet those cultural standards. We often get stuck as well in rehab of just thinking of sexuality and sexual pleasure within the box of heterosexual marriage or even of in relationships in general. And we forget sometimes that for some people it's very important that they have the physical release of tension and experience that they would have with masturbation, and that's a legitimate sexual pleasure and sexual experience. So we have to be able to make sure that we're keeping our minds open in what we even consider under this topic. And also the other thing is that sometimes that idea of sexual pleasure as something that we would tie into treatment or to research is viewed as something still that's a lesser good and gets often tied up in language about sin, sickness, perversion, whatever. And we have to be sensitive because sometimes these are the experiences and the framework that a person is coming to us with, and other times it may be our own issue and our own framework that we have to be careful that we're not imposing on others who may be seeking our care through us, and that if we do have certain issues there that make it difficult for us to be the care provider, that we know how to refer that person over to someone who can appropriately meet their needs. So why is it important to even deal with this? It's a key part of being human. It's a big motivator. It's part of our self-esteem. It's in the World Health Organization's International Classification Framework. When you go to the literature and actually hear the stories of people with brain injury who are moving on in their lives, relationship, sex, and intimacy is very critical and is raised in position papers going, back 20-some-odd years ago as being something that was viewed as important and not always adequately addressed by professionals. So what are some of the overall findings? Problems with energy, desire, and drive, problems with orgasm, problems with positioning and movement, and of course pain, which often becomes more of an issue with aging. Problems with confidence, body image. How do you sexually satisfy the partner? How do you deal with being disinhibited or having a hypersexuality? How do you deal with things that may involve bowel and bladder issues, the need to use adaptive equipment, the ability to even fantasize and hold on to sexual thoughts in your head? So with this, we have to also remember that many people's issues with sexuality and intimacy may predate the TBI. Now, unfortunately, I seem to have lost the network connection. So I apologize if folks could just hold on a moment while that connection comes back up. Great.
We're working on getting that right back up to you.
I got it. And then, why is it that our field hasn't looked at this more seriously? Well, part of it is that a lot of our outcome measures, the things that we're evaluated on or that our research is based on, don't even include items related to sexual functioning. Think for yourself in the settings that you work in. Are there questions related to that? When you're screening people, whether it's for intake or whether it's looking at programmatic satisfaction or achieving their outcome goals, do you talk about sex and intimacy? The other problem is who's treating it? What are you treating it for? How do you enter a code? Who actually do you bill that to, and do they pay for it? And then oftentimes, people simply don't get referred to practitioners who have that expertise. And I mentioned the Institute for Sexual Medicine in Boston. It's one of the long-standing places that provides treatment, and they had provided me some data a long time ago, so I don't want to go into specifics, but the shocking thing of it was that when you know how prevalent TBI is in the general community, and you know how many issues there are with sexuality and intimacy after the fact, the number of referrals they got for people with TBI was abysmally low in comparison to other medical conditions. So there's problems of why we don't necessarily get involved with this. Sometimes it's our own stuff where, we don't necessarily know. There's so many other big problems. Why should we even be addressing this? There's often some beliefs and stereotypes that if a person with TBI may present as more childlike, more dependent in relationships, well, maybe sex is not for them or they're not really interested in it. And there's also times when it's embarrassing or we're imposing our own personal view on that person's situation, which of course is, something that makes us then less approachable. So looking at the brain parts, a lot of them are involved. It's a complex behavior. So you have the underlying structures, like your limbic structures that drive behavior for the survival of the species. But then you also have the more sophisticated functions of the frontal lobe that help you to refine ideas of compatibility, attraction, opportunity, planning, that all go into having satisfying intimacy and sexual behavior. And last but not least, there are those things called hormones, and our endocrine functions play a key role in sex drive and fertility and all kinds of things of that nature, and they can be effective and are affected at a much higher rate than people realize post-TBI. And often individuals are not screened in this regard because people with all of the other things going on don't necessarily think about the endocrine functions, and yet that's vulnerable to actual tissue damage to the brain, especially when you have injuries that are around the whole pituitary region, which is that area around the pituitary where a lot of our hormonal drivers are. We have a few general things. We know that people with mild TBI report more sexual dysfunction, but they also tend to report more depression, more anxiety, and other things because I think there's a keener awareness and proximity to one's former life and then that greater experience of loss. We know that there's the gender issues as well. Women have a bigger interaction effect with the endocrine system and their experience of depression, also more complaints of vaginal dryness and difficulty with orgasm. With men, the problems tend to involve erectile dysfunction, and that can be medication-related as well, also with premature ejaculation or the inability to have an orgasm. And, when we talk about these medication effects, I want us to keep in mind that a number of the medications that are commonly used post-TBI do have side effects that can affect sexuality. For instance, that's quite true, especially for women who are on antidepressants, the SSRI family. And, there's a laundry list of these. So we need to be keenly aware when people don't want to take their meds, is this one of the reasons? And do they feel comfortable even sharing that with us? Because there may be substitute meds that wouldn't have that same side effect. Looking at the neuroendocrine problems, the studies looking at pituitary damage find that 40 to 62% of people with TBI have some damage around or in the pituitary. Because remember, it's not just in the pituitary gland itself, it's also in the pathways that it stimulates. Hypothalamic lesions, because the hypothalamus, I always joke around with neuroanatomy class, that's the part of the brain that controls our animal functions. And you can always remember it by remembering the 4 F's, fight, flight, feeding, and reproduction. So that part of the brain also has about a 42% rate of injury. And from this, you have changes in the neurochemistry that then affect changes in our sexual behavior. There's also secondary causes of sexual dysfunction, and these include classes of physical, cognitive, and behavioral symptoms. So the physical include things like spasticity, hemiparesis, ataxia, problems with balance, problems with movement, problems with sensation. It can also include problems with bowel and bladder, which are implied here, but can explicitly be the case. If, for instance, you are utilizing a catheter for urination, how are you going to manage that in the sexual arena? And knowing that you have to manage that, how do you then discuss that in an intimate relationship? How do you develop the confidence and self-esteem that you can have that dialogue with somebody, that you can work with a partner that would be, loving and in a kind way, be able to figure out how best to address that sexuality-wise. And there are very pragmatic ways of how you deal with all these kinds of things that allow for still very wonderful, pleasurable sexual experience. Here's a quote from one of Angel's clinic clients related to the physical issues. Before, he was able to do a lot more things. As far as now, it's just me having to do everything sexually because he just has to lay on his back. It's very tiring. And this was a clinic where couples were being seen post-TBI as part of a research and treatment study. Now, on the cognitive side, issues with attention and concentration, the ability to initiate sexuality versus having a more general apathy or depression, and also the things that you need to do to have sexuality happen. It's a lot more appealing to have a partner who keeps up their ADLs. It's a lot more likely that sexual intimacy is going to be successful if you have ongoing contact and you're developing that warmth and that whole experience that gets bundled into the intimacy of a sex act. That you can communicate socially even on an intimate level, that you're aware of how this occurs, the context, how it's coming across. And also with the executive functions, there's a lot of planning that occurs. I know, if you're in a relationship with someone and let's say you're both working, good Lord, you have to really plan this because you're so busy, you're often tired. You may not be coming home at the same time. You may be trying to deal with who's getting the kids. There's all kinds of things of that nature that occur that then create problems. So it's important to keep all this in mind when you're taking a look at the different cognitive aspects because they range from very basic issues of can you pull this together to, have enough drive and be able to contemplate how versus being able to coordinate a complex life and relationship. Here's a quote on that from the clinic. And it's difficult when you're struggling so much to think clearly and recover. It's difficult to have the extra mental capacity to think about these other activities that in the end lead to intimacy and lead to physical affection. Now, there are also secondary causes of sexual dysfunction that are more emotional or behavioral in nature, and certainly the biggest one is depression. People who are in the midst of depression do have much lower rates of sexual behavior, and that doesn't matter if you've had a brain injury or not. But we know that brain injury can run to roughly about half of people with TBI have that at some point after their injury, and oftentimes it can be viewed as being apathy or disengagement or other things that don't necessarily leap out at you and present, oh, this is depression. But it suppresses sex drive. It suppresses a lot of drives toward things in life. Other times, too, emotionally, a person may adopt a less mature or dependent position in the relationship after the injury. They may be more self-centered, especially if there's frontal lobe injury. I mentioned before the apathy. That can be a big issue from an emotional drive standpoint. They may be disinhibited and have trouble self-monitoring, not always knowing how they're coming across, maybe coming off too strong or even in ways that are violating someone else's physical space or someone else's, rights. And a person may also struggle with issues related to their self-esteem and their body image. Am I still desirable? So these things also occur. And from the clinic, this was got a very compelling quote. They can't emotionally connect with you, so you're having to carry them emotionally, physically, sexually, psychologically. You're just carrying the whole thing. And then there are those things that occur within the context of family roles. The roles change. There's huge financial stress, a lot of social isolation. People become exhausted. And, you know, everybody rallies around the flag very shortly after the injury occurs, but then often that help and support and those social interactions can drift off. And a couple whose life as a couple was enriched by having these other resources and people around them can end up really feeling just stuck on an island together. And it can cause huge challenges on how to support and make that relationship still be dynamic. They can have problems with communication and just problems, you know, not having the kinds of people around that make all of our relationships better. And this last quote from the clinic, she's more or less the leader, whereas I think I had that role previously. So now I have to be a better follower, more or less, and that's a change. And when you're a follower, you're less in control of things. You know, and that dynamic of who's the person who's leading or taking the more aggressive position in pursuing sexuality, if that changes afterwards, that whole dance of the relationship changes, and it can be quite a challenge. So here are the classes of medications, just to keep those in mind when you're looking over people's histories or wondering about it. Anticonvulsants, antidepressants, anticholinergics, and a lot of the serotonergic agents, which are, you know, the Paxil, Prozac, Trazodone, Effexor, that whole family of medications that are commonly used to alleviate depressed mood. That all of these can have an impact, and there's others as well, but these are the ones that you see the most commonly prescribed post-TBI. So what are some changes in sexual functioning? Well, 58% of males report some kind of a problem in one of these areas, and these were the most common ones compiled across the different studies cited at the bottom of the slide. Failure to obtain or maintain erections, decreased desire, decreased ability to have orgasm, problems with ejaculation, problems with the frequency of sexual activity, and an overall decrease in quality or satisfaction. More studies have been done on men than women, and that's for two reasons. One is that it's a higher percentage of men who are injured versus women. That's still true, even though the gap in it is not as big as it used to be. Also, you know, research in general was predominantly done on men versus women. Historically, it's, you know, kind of an extension of other things that go on socially where women are at times disadvantaged. And definitely in the biomedical research, men have been used to gather data more than women have. However, Mary Hibbard and colleagues, Dr. Hibbard was at Mount Sinai at the time, did a nice comparison study comparing women without disability to women who had had TBI, and found that there was significant difference where women with TBI had a much higher rate of pain during sex, difficulty masturbating with vaginal lubrication, troubles or difficulties with positioning and movement, with sensation and orgasm, and with body image. Hypersexuality gets a lot of buzz and a lot of attention, but comparatively it actually occurs fairly rarely after TBI, and it's usually related to more significant frontal lobe injuries. And you often see it in the context of people who have general disinhibition, trouble self-monitoring. But the thing about it is it's very distressing to the people who are around that individual, and thus it rises to the top of the heap when it does happen. There are a number of treatment approaches that involve social skills training, more formal behavioral interventions and behavior modification, and in extreme cases where individuals are, you know, at risk for being isolated from society or perhaps crossing into scenarios where they might be subject to criminal arrest or violate someone else, you know, there are pharmacologic interventions that range from mild to much more controversial and significant. But just to keep in mind that this problem gets talked about a lot, but it doesn't happen as much as individuals with TBI not being able to have sex or intimacy, being hyposexual, apathy, loss of drive, or not being able to find relationships or partners. So while it gets a lot of the press, I would suggest that statistically it doesn't happen at the same rate. It just sometimes seems like it happens more because of the attention it gets and how distressing it is, and that it's difficult to treat. we have to look at our history of how we've looked at sexuality and disability as a whole. You know, it wasn't all that long ago that people who had disabilities, particularly cognitive disabilities, whether they were developmental or acquired or traumatic, were forced to be abstinent, were punished for sexual behavior, or were involuntarily sterilized. Many states did not lose their involuntary sterilization laws until well into my lifetime, and I'm not exactly an antique. We also were stuck in these different models. One was an innocent model where we had to protect people with disabilities from the public and the risk of unwanted sexual advances. Then we also had degenerate models. Well, we have to protect the public from people with disabilities, especially negative stereotypes about mental illness, you know, who might be pursuing members of the public sexually. So those were two things that we kind of had to overcome. Then there was also the issue of how we dealt with normalization. There were a lot of efforts at mainstreaming, integration, all of this that were really wonderful, and they're what we've all moved toward. Community living, absolutely. But when those abstract rights hit the explicit realities, that, you know what, if somebody's going to live in the community and you say, I want these individuals with disabilities to have the same rights everyone else has, that means they have the same rights to risk, to do stupid things, to have multiple sexual partners, to engage in orgies, whatever it is that the rest of us, we have a right to. We may or may not choose to do it, but we have that right. And when those realities kind of hit you in the face, particularly as a healthcare provider or as a family member of somebody with TBI, it suddenly becomes a little bit trickier ground of, you know, these rights and equality is suddenly not so abstract because, you know, we all have the right to make stupid mistakes and get in bad relationships, but we really wouldn't wish that on anybody. So that can be a very delicate ground and one that I think communication is the solution for. So there's also barriers to health, and that often is that, you know, because of the stereotypes about people with disabilities, they may not have the information that other people have and therefore are at greater risk. So it's important that we do provide, you know, appropriate in terms of reading level, complexity, timing of exposure, you know, resources around health and education for sexual matters, and also make sure that individuals understand their right to freedom from exploitation or abuse risk. That's critical. We also have to appreciate time and gender differences when we approach this. What's interesting is that the longer somebody has a disability who acquired it, the more positive their sexual feelings become because they adjust to their new identity. Not true for 100% of people. Some have a lifelong struggle. But it tends to be the case. We also know that there tends to be a higher divorce rate after this happens. And interestingly, when a couple forms post-injury, they report having better sex with one another than a couple that was together before injury and is then having sex after the injury. And that's because we tend to compare the sexual experience with what we had before, not realizing that when someone has an injury, particularly a significant brain injury, their communications, response, all kinds of things are going to be very different. And it's not going to be necessarily like it was before. We also know a few things, that the biggest concerns for males tend to be around performance, and the biggest stressors for females tend to be around appearance and self-esteem. The key thing here is that throughout all of this, there's a role for healthcare professionals to have a positive impact. So some of the key things of having a positive impact as healthcare professionals include preventing sexual victimization, really educating people about their rights, that you have a right to say no at any time, warning signs for exploitation and abuse, understanding consent, but also understanding that people have a right to sexual information, to sexual relationships, and to marry and have children. Competence for sexual consent can be a discussion that would take up a whole presentation in and of itself, but typically that's done, you know, in conjunction with a behavioral health professional because it's looking at the cognitive factors as well as ensuring that there's a balance of protection from harm and promotion of rights. There's a number of frameworks for this. I mentioned one in here, but you know, it is a pretty complex process, and it occurs in the best way if there's a good communication and a dialogue about it. There's a lot of gray zone here, and we have an unfortunate history of individuals with disabilities being denied the opportunity to engage in intimate and sexual relationships for no reason other than it made the non-disabled people in their lives uncomfortable. So there's a very delicate balance. What do we know about intimacy? Because intimacy is the foundation for good relationships and a good sexual life. Well, we know that there are intrapsychic characteristics in these that have been demonstrated in the psych literature. And here's the kind of the core factors: knowing yourself, accepting yourself, knowing your strengths and weaknesses, being able to relate to people in self-respecting ways, being able to experience and share emotions, and feeling that you're worthy to have this pleasurable, wonderful experience with another human being. Some of these things can be affected by TBI, especially with frontal lobe injuries. Sometimes it's more difficult to experience and share the emotions. Sometimes it can be more difficult to appreciate your newfound strengths and weaknesses after the TBI. So we know that some of these matters can have impact intimacy, but they're also great targets for treatment to help somebody with those arenas of life. Then we also know when two people come together, there's characteristics of interpersonal intimacy, and they generally fall into these four areas. The first is the psychological one. People have more successful intimacy when there's good alignment in terms of self-esteem, awareness, respect, commitment, and intellectual compatibility. That can be difficult if someone's had a more severe injury and their ability to be self-aware, their ability to engage in intellectual exchange becomes seriously compromised. Emotionally, there has to be a platform for the intimacy to occur. That has to involve the ability to communicate, including listening, to be able to share and appreciate the perspective of the other. Again, with severe frontal lobe injuries, that at times can be affected. Operationally, this is one that really can tip relationships that have been existing for a while because roles change, responsibilities change, who's in control at any moment changes. And in these instances, certainly couples counseling can make a huge difference because a couple may not even realize that that's what's going on here. That's why there's no spark. And lastly, the shared part of life where we have activities, hobbies, our family traditions, the things that we've done with our friends and in our community. You have to maintain and prioritize as much of that as possible. Life isn't just about going to PT and therapy and whatever it is. You have to keep this other stuff up as best as you can, even in those days, post-injury where it can be extremely tiring, because those give the color and vibrancy that helps move intimacy along. So post-TBI, we know there's issues of lower marriage, higher divorce, lower dating, older age of first date when people are injured as youth, problems with where you live, how you get around, the access, problems that can occur in the relationship up to and including domestic violence and rape. And a lot of issues that have been shared, I know, my own clinical experience with trust and feeling vulnerable and feeling that change in control that can make it really difficult to have that openness to intimacy that leads to the best and strongest relationships. One of the things that doesn't change very much is often TBI has no impact on conception depending on if there's a significant endocrine involvement or not. There can be physical issues that need to be addressed medically. Also, you have to look very carefully at what medication someone is on because some of the meds used for seizure control and other things like that can be ones that are not recommended to take during pregnancy. Big issues include aspects of health, nutrition, medical access, and those are all primarily driven not so much by the disability itself, but by the poverty and difficulty accessing the healthcare system that many people have after they have acquired a disability. And last but not least is parenting, which unfortunately we don't address very much in rehab. There are some curricula available for that, but parenting is a complex set of skills. And then again, it comes down to that issue of what profession is going to take that on? What CPT code do you use? How is it billed for? Can you set up peer support groups to help with coaching and parenting, especially if this is a first child? So that's one of the challenging ones that I think is a real weak spot in rehab. We also have to keep in mind that we have increasing numbers of sexual minorities and subcultures. We have not had gay marriage on the books across the country all that long. I've lived my life in the Northeast where that occurred much further in our past, and I think there's been a good adjustment to it. There's parts of the country where there's still quite a backlash occurring. And we have to remember that, within any of the sexual minorities and subcultures, there are other issues there, and we need to be sure that our approaches are at least open enough that even if we're not comfortable addressing those issues, someone feels comfortable enough with us to raise them so that we could refer them to someone else, and that we're cognizant to make sure there's not homophobia in our environments of care or support. Also, to know who's educated and who's the referral source in your community or on your team for sexual minorities and subcultures, because there may be different needs, whether that's related to sexual practices or the cultural elements of dating and meeting people. And, seek the basic knowledge if you don't have it, to at least know who to refer someone to, and to be as open and taking a reasonable sexual history so that you can identify those issues. Sensitivity training for staff. University of Minnesota, and I apologize, I meant to check this number because I haven't called it in like a year or so, but they had published online a training program for staff of how to become more comfortable and more approachable so that patients of all types could speak to medical and healthcare professionals of all types about sexual issues, because they're one of the least discussed aspects of healthcare. So I think, different programs have come up since then. Might be good to identify what ones are suitable for your area and to be really cautious with that. Early on in my career, I relocated from working in Manhattan to working in a rural care setting up in the White Mountains. And boy, there were times where I would, try to explain or discuss things, having no idea how completely out of context and misunderstood some of those things were. And it was a real eye-opener after the fact to, appreciate that the more and the understanding of things were so different. So it's a good idea to, when you're looking at those training resources, to figure out what's appropriately applicable in your setting. And why is this important? Well, we know with intervention, a lot of people never even talk about this, and yet they get information and feedback about their sexual problems either online or from their friends. Not only can some of those things be harder to access after TBI, but some of the information is really horrible, and it's not real, and some of it's flat out dangerous. So we know interventions tend to follow the implicit model, which is that, initially you're just giving people permission to be able to raise those kind of issues. And then it may be you're comfortable giving limited information, but it may be that there's other people on your team or specialists from whom there's specific suggestions or that you would refer for intensive therapy. But, when you're looking at what's going on in rehabilitation settings, we should at least have the basic skills to help prepare people with disabilities that have the potential or are affecting sexuality, intimacy, and relationships, to be able to get the basic skills training around the educational and mechanical aspects, to be able to work on social skills, rituals, and dating. And nowadays it's very complex because a lot of it then transpires on social media, less face-to-face now, and then understanding how to implement those therapeutic interventions in individual, group, peer, and community settings. There's a lot of techniques that are involved when people are getting into more explicit sexual therapies, including how to even know about one's own body and how to pleasure one's own body, because how can you in a relationship explain that to somebody else if you don't really have any clue how it works? And then also looking at all of the different kinds of factors that come in as common interventions, being able to have sensation focus outside of the genitals, to be able to have an understanding of what are your options for positioning, rehab technology, sexual devices, being able to handle issues of impulse control and planning. Those are all common things that come up after TBI. And the whole idea of when and who and how you do this can be complicated. I've had situations where the individual was a young adult, they were cohabiting with someone, but after the TBI, the parents swooped in, and they were suddenly in charge of and driving everything, and that person with whom the individual with TBI had been cohabiting for quite some time was kind of left out of the loop, and they didn't really have any standing. So it became very tricky of how do you engage with the system or the circle of that person, and at what point do you then interject that? Even the question of, the person didn't want to go home to be with their parents, but they needed the support that the cohabiter could not provide. So then how do you arrange, quote, conjugal visits? Things like that you wouldn't think of, but they made a big difference. When you have a referral for sexual-related problems, you want to make sure that there's a comprehensive medical evaluation and that you know in your communities who is sensitive and competent and thorough about that. The benefit of being in a northeastern state that is fairly densely developed is that you have more resources than trying to accomplish this in northern Maine, as an example. Though there are some people in northern Maine. Took us a while to find them, but we did. And then the idea of looking at relationship therapies, because the biggest sex organ we have is our brain. So you have to understand that sexuality is a communicative tool that happens in a dyad, that we all have sexual scripts in our relationships. And sexual problems can really mess a relationship up on all levels. And there's aspects of timing and place and person that occur. I like to think about the 4 key ingredients to maintain a positive, sexually intimate, erotic energy within a relationship. And that has nothing to do with whether or not you have a TBI, but it's directly related to what you need to target in the couples therapy. And that is, do you have adequate time together? Are you able to talk to one another? Do you have the trust necessary to have the full intimate experience? And how are you touching each other? Because those 4 T's are the underpinning to keeping that healthy dynamic going. And they're all impacted by TBI, but they're all viable targets of treatment for the sexual aspect of rehabilitation. All of them can be addressed therapeutically, and they make a big difference. I challenge all of you who are partnered in relationships to really think about the 4 T's and how you can take one step in each of those areas to improve your relationship. A little more time together, maybe a little more listening when you're talking to one another, taking some kind of a risk or adventure together to build up your trust, and touching each other a little bit more, whether it's a massage or a hug before you go out the door, whatever it is, because they all make a difference. In relationship therapies, you first have to accept that the purpose of being in therapy is you're accepting that you want to have some kind of change. And you have to develop the communication around that, doing that in a positive, loving environment, and be able to then pick up your desire and arousal through anticipating that you're moving toward enjoying intimacy together, and then dealing with the issues that actually come up on the physiological level. There's the Davos cycle, and we're not talking about an economic summit in Europe, but that is the cycle that we all go through of desire, arousal, vasocongestion, orgasm, and satisfaction. And most of us flow through that cycle. It's been conceptualized in different ways, but that's the general framework of it. And if there are problems along the way, how are they addressed? Because are they physiological in nature? Are they more psychological in nature? There's a few that come up. One is performance anxiety. Sometimes people anticipate and then they get very stressed out, and that can cause significant issues. Spectating, or somebody who's what we call like watching their own performance, and then they get the negative self-talk, and that really can make for a negative experience. And often when people are doing the self-talk, they're saying, no, 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 don't think about that, don't think about that. And that then worsens it even further. And also when people just have the flat-out loss of desire. So we also look at the dance of communication, how we convey the interest and intimacy. And this can be a very challenging thing after TBI, especially if people have injuries that affect their ability to appreciate some of the nonverbal aspects of communication, the prosodic elements of speech, body language, inflection. And if you think about the complexity of behavior, flirtation and granting permission and all of those things are very, very complex, much more complex than learning most job skills. Because you convey attraction through how you use your eyes. How long do you let your gaze rest on somebody? How do you position your body? How do you actually touch yourself while you're talking to and looking at someone else? How do you touch them? You know, if you touch somebody with a pat on the back or on the upper arm that's firm, that's sending one message. But if you take that same upper arm and you softly drag your finger down it as you're talking, that's a totally different message. Same body parts touching, totally different message. How do you have an opening line? How do you flirt? You know, the other thing with that is the very delicate timing when you're building a sexual relationship of what you disclose about yourself, how you listen to the other person's disclosures, and you build and invite more and more intimacy, almost like, you know, going up a flight of stairs. How do you communicate? The vertical communication versus the horizontal communication that is sexual in nature. The vertical communication is you come home from the day's work and you're both at home together and you know, you're making dinner and your partner looks really great in the pair of pants they're wearing. You say, boy, you look smoking hot in those. Well, that's, you know, you're sending the message. And then the horizontal communication is a nice way for saying, how do you communicate while you're in bed? Like, you know, oh, wow, that's just great. Oh, my God, don't stop. You know, you've got to be able to understand how to convey those things for it to be a good experience. And, you know, when you're working with a couple, obviously you're having to have a lot of trust as a clinician because you're asking them to disclose and share in and work on issues at that level. You also have to keep in mind their personal inhibitions from anxiety, from cultural, religious practices, all of that. But there's a lot of great psychotherapeutic interventions you can do, building on social pragmatics, building on scripted interventions, and encouraging certain aspects of participation. Male sexual health, overall problems, the biggest one that gets a lot of issues, a lot of press is erectile dysfunction, but there's all these other problems that occur as well. And this is male general population, not just TBI. Erectile dysfunction is the biggest concern. There's a lot of superstitions and cures out there, people wasting money making themselves sick. There can be all kinds of causes. The focus tends to be primarily biological, but sometimes it is psychological, sometimes it's neurological, where the regular biological cures or treatments like Viagra are not able to be successful. There's a lot of different interventions, and I think everybody's very familiar with the pill form, somewhat familiar with maybe psychotherapy if there's anxiety or relationship issues. But for people who have significant neurologic problems, including those who have spinal cord injury, there may be the need for more extensive treatments, including vibratory and electrical stimulation for ejaculation, or the implantation of prosthetics, or the use of constriction tools. This is a similar warning that you would have to the other pharmacologic tools. It essentially functions like the cock ring you would see in your classic sex shop, where it constricts the blood flow, causing a vacuum to draw the blood into the penis. The ring goes over the base of the penis, holds the blood there, but you can't leave it on for very long because it causes damage to the tissue, just like there's always those TV warnings. If you have an erection that lasts more than 4 hours, you need to go to the ER, because you have to keep circulating blood flow in order to not have any damage. For individuals who have the total loss, there are implants, including, this is a pump version where there's a fluid reservoir and a pump feature with a release valve. that allows for full erection and full flaccidity. Most Medicaid plans do not cover this. They instead cover what's called the semi-rigid rod, which is a partial erection and never entirely flaccid. It's a bendable rod. They're usually guaranteed for a certain number of bends. So the problem with that, with either of these systems, is they can break and require a secondary surgical intervention, but they are options for individuals who have the neurologic loss or the loss of circulatory function to be able to have erections. Ejaculation difficulties can be very subjective. It used to be premature ejaculation was diagnosed by the opinion of your partner, but we know that doesn't make sense. Treatments involve masturbation with the start-stop techniques, and there's all different forms of hyperstimulation for individuals who can't ejaculate, and subduing the sexual act for people who ejaculate prematurely, including ones that accommodate hands-free. That's the one that's attached to the easy chair. It was designed for individuals who are looking at pornography on the internet, which it becomes an addiction for many people. I'm not an advocate of that in any way, shape, or form. However, for individuals with TBI who have loss of use of their hands, the device actually works very well so that they're able to engage in a masturbatory activity. The premature ejaculation, as I mentioned, involves the start-stop technique when you're reintroducing couple sex, starting in the female on top position in order to have more control and then be able to move on to other positions from there. This positioning aids, they're not only good for paralysis or hemiparesis, but also are really good for those of us who are aging to make sexual activity easier, less fatiguing, less tiring. For women, there's always been that debate about the clitoral versus vaginal orgasm. I know for me, I'll take them however I can get them, but it became a big issue. And the reality is most women are multi-orgasmic, and the number or location of orgasms and how they have them, how they prefer to have them, is very subjective. It's not at all uniform across women. And the issue with that is that in the general population, 98.6% of women report some sex problems over the course of a year. 72% report often or more. Low desire and is treated by biopsychosocial interventions. It can often be general health, hormone, or relationship related. We also have to remember there's a slightly higher rate of past trauma for women than men. Problems having orgasm may be linked to inadequate foreplay or stimulation. Also may have issues related to vaginal dryness and discomfort, especially after menopause, or women not having as much knowledge about their own bodies. More products are available for lubrication, some of which have features that increase arousal. And then there's more and more sex toys on the market, but this is a buyer beware phenomena because many of the sex toys are coming into the market that are from China that involve plastics and substances that are cancer-causing. So you really want to look for medical-grade silicone and be very careful about that. There's also problems that women have neurologically and psychologically that involve both spasm, which is vaginismus, or then problems with urinary incontinence. So there are dilators used for spastic vagina treatment that allows for gradual releasing that can then accommodate penetration. And then there's also vaginal barbells and exercise devices. And you laugh, but that Susan Summers thing that she was peddling for years to firm up your thighs actually helps to tighten and reduce the risks of urinary incontinence for women in general and make sex more satisfying. In closing, I just want to mention sexual addiction. It's a big problem because it's anonymous and all, and there's all these kinds of dating versus sex partner sites. People can get themselves into big trouble with that. So open discussion and understanding of the risks is an important thing. Treatment-wise, it's very much like 12-step models. In many instances, that's helpful. Also, at times, antidepressants are helpful, and really trying to get people to engage psychotherapeutically around this and have some relapse prevention strategies. Having a healthier lifestyle and the support of your partner is also big. in this thing so it doesn't become a hidden behavior and continue on indefinitely. I think I'm getting tight on time, but I just wanted to mention that there are a few case examples in the slides, and all of them involve the engagement of a counseling process and being able to help the person come to positive sexuality and that kind of experience without shame or embarrassment, and treating it like any other rehabilitative problem, including looking at it within the context of family issues, guardianship, and those kinds of situations. So these slides are certainly available and have the examples on them. Now we do have a few questions that came in. And one is when you have the change in role where you're someone who did not have to more aggressively pursue sexual contact, but now you have to be in that situation where you're having to be more assertive, it sounds like. I don't really, the word aggressive was used in the question, but I think more assertive. And, you know, I think when we talk about social scripts and social pragmatics, you know, that's something that whether it's through the context of a psychotherapeutic or trusting relationship, that you can try those things out to see what feels comfortable and, you know, how you want to then handle yourself in those scenarios to be able to identify even what's the setting to assert yourself in that you want to meet people and want to have that opportunity. You know, I think that's a difficult thing to try to address in any kind of a support group format, other than talking about it more in generalities, because it can be kind of awkward. And you do want an opportunity to put some of these scripts together so that they feel comfortable to you before you go out there and try that level of engagement. Let me see here. I'm trying to open up.
Dr. Trudell, I received a question that came in from Mallory. She works in an inpatient rehabilitation hospital for patients with TBI.
Yep.
And she asks, what would you recommend to implement in this facility? A class for patients, education? What are your recommendations?
Well, when you're talking about an inpatient setting, you know, it can be a very bizarre thing that like, you know, you don't want to be in a scenario where you have an individual who's just coming out of coma with all kinds of complexities, and you're, you know, asking questions about, you know, how frequently they were having sexual relations or something. So I think with that, in that kind of a setting, it would be important on your rehabilitation teams to identify, you know, who's the go-to person, who are your resources. If you have to refer for couples counseling or for actual sex therapy interventions, to make sure that everybody on the team knows what are those referral sources and how do you access them. And that you're all clear as a team of what your comfort zone is. Because when you have that kind of clarity, you create a much more approachable environment. And then, you know, you as a team, depending on the nature and severity of what somebody's going through at that point in time, can decide what's the best way to try to bring this up, just to open the door. And typically that would be done in the context of asking about other things. You know, do you have any questions about your medications? Do you have any questions about how this, you know, injury may affect your sex life or your sexual performance? You just putting it in as a normal thing in terms of some of the questions that you would typically be asking of someone, and then that can help you push it in the right direction of whether it's not an issue or it's something that needs to be addressed. And the other thing that's key, because people are very overwhelmed in that situation, is to have a handout about relationship, sex, and intimacy that gives people the information that, you know, if you have needs or concerns in this area, you know, here's who you can contact. Because people take that stuff home and, after they're through just the shock of everything and they're beginning to settle back into life, that's where some of these issues may emerge. And you'd be surprised how many times those things that you hand out to people, suddenly they look at them again and they realize that, oh, this isn't abnormal. This happens to other people. It's not just me. And then they feel more comfortable that they can talk about it and ask about it.
Thank you, Doctor. I know we've gone over a little bit. We just have I'll go one more question unless someone else has something they'd like to send in. We received a question from a gentleman that sustained a brain injury and has said he shied away because of rejection or even being accused of stalking when in fact he thought that the other person liked him.
Mm-hmm.
So well, he was there. Go ahead. I'm sorry.
Yeah, that's a challenging one. I think there's two parts to that. The first is the risk of rejection. We all have that experience. It's a huge issue, and certainly we live in a culture where judgments are made that people are more judgmental, perhaps, if there are physical differences or they're looking for who's got the money and the flashy car. But those aren't the real relationships you want to be in anyway. So I think with the rejection, the key thing with that is be forming a relationship with this individual to be certain, is this someone that you really want to have a meaningful sexual intimacy with, that you really want to take the time and develop that communication with. And then if you're giving that some time and thinking that through and experiencing that relationship first as a non-sexual intimate relationship, it'll become more clear if this is a good fit or not, and the odds of rejection will be less. The other thing is the accusation of stalking, and that happens at times to individuals with TBI more often than the general population, because there can at times be subtle difficulties reading nonverbal communication. And I've seen it happen more often in males who have sustained TBI pursuing relationships with women, where they may not be reading all the nonverbals, and that because that individual may be identified as someone with a disability, the woman involved is actually conveying empathy, and it gets misread as attraction or interest. That's a very subtle thing, and one that, with trusted people, to get some feedback about, so that you understand how you may or may not be missing certain aspects of the nonverbal communication, because it can become something really unpleasant and dramatic that it simply doesn't need to be. And it's a good thing to be able to work on being increasingly sensitive to nonverbal communication cues and to understanding what people do to be socially comfortable or to avoid a conflict or to avoid tension that really is not what it appears to be based on the words they're using. Those aspects of communication are challenging under the best of circumstances. And with TBI, they can be more different, but it's a skill that can be learned and improved upon with time, but you have to be willing to get feedback about it. And, the other thing is it may be that that was just an icky person, but not let that cloud, your experience overall, that was just one person.
Okay, well, thank you so much, Dr. Trudell. At this time, I'd like to take time out to thank Dr. Trudell for volunteering her time to present on such an important topic. If you did send in a question or you have any questions after we complete the webinar, please, you can email them to myself, which is ljacobs@bianj.org. That's ljacobs@bianj.org, and I will make sure that it is forwarded to Dr. Trudell.